prokinetics and digestants. So what are prokinetics? Prokinetic drugs means the drugs which promote gastrointestinal transit and speed gastric emptying by enhancing coordinated propulsive motility. So this excludes the traditional cholinomimetics and anticholinesterases which produce tonic and largely uncoordinated contractions. So there will be speed of the gastric emptying. It will be that will be made in high speed. Then there will be coordinated propulsive motility. It is not uncoordinated as in the case of cholinomimetic drugs. They are actually prokinetic drugs. So names of the drugs are metoclopramide, domperidone, cisapride, mosapride, etopride, levosulpiride, and cinitapride. So once again, metoclopramide, domperidone, cisapride, mosapride, and etopride, and levosulpiride, and cinitapride. So we will see one by one. All are important. Number one, it is metoclopramide. Metoclopramide, so it is a substituted benzamide. It is also called a gastric hurrying agent because it increases the speed of the gastric emptying. So you can see we will see the different the parts of the stomach. It is fundus, this is body, and this is antrum, and this is pylorus. So here there is usually there will be a sphincter will be there. Then there is another sphincter here, gastroesophageal. This is esophagus, gastroesophageal. So we will see because this metoclopramide, it is an anti-emetic also. At the same time, it is a prokinetic agent. Its actions mainly in GIT and in CNS. In GIT, what happens? It increases gastric peristalsis. So the peristalsis, it will be increased. Relax the pylorus. This pylorus, it will be relaxed, and it will be and also the first part of duodenum, and speeds up the gastric emptying. So this is relaxed. This is relaxed. So the emptying will be made faster, and there will be increase. It increases the gastric peristalsis because it is from the contents are taken from stomach to duodenum faster. So the transit it is made faster, and this sphincter tone it is increased. So that means it is contrived. It is closed, so that there won't be any regurgitation from the stomach to esophagus. So this is everything. It will be emptied from the stomach into the duodenum. So this is happening in with metoclopramide in GIT. In CNS also it has some action. CNS, it is an anti-emetic. It acts on the chemoreceptor trigger zone, and it acts as an anti-emetic. I think you would have studied already as anti-emetic. And in addition, the gastrokinetic action also contribute because everything from the stomach it is emptied. So the vomiting sensation that also will be reduced because of using this metoclopramide. In addition, it has got some central action on this chemoreceptor trigger zone also. So this picture we will just have a look. This is from Tripathi. So if you study this picture in a mechanism of action, it will be very easy. So I will tell you what does it mean. So this is called EC means enterochromophene cells. So this is the stomach. There is a stimuli. Here there is the lumen. So any stimuli from the lumen. Please listen carefully. So we will study this mechanism. Then it is easy for all drugs. So when there is a stimulus into the enterochromophene cells, there will be liberation of this 5-hydroxytryptamine or serotonin. And it will be acting on different receptors like 5-HT3 receptor, T1 receptor, as well as T4 receptor. Okay, and from the enterochromophene cells, 5-HT or serotonin, it will be liberated whenever there is a stimuli. And it will act on 5-HT3, 5-HT1 and 5-HT4 receptors. So what happens? So when the 5-HT is released, there are two type of the neurons. There is extrinsic neurons that will go to central nervous system, and there is an intrinsic pathway also. Intrinsic, it is both. This is excitatory. I'll explain again. And this is inhibitory pathway. Inhibitory, and this is excitatory. So 5-HT is released, There is an extrinsic pathway and an intrinsic pathway. Intrinsic again, it is intrinsic excitatory as well as intrinsic inhibitory. So, what this everything means what? So there is one another receptor called the 5-HT4. So anything which is activating this 5-HT4 receptor, there will be liberation of acetylcholine and calcitonin gene-related peptide. So acetylcholine and CGRP. So you know that whenever there is acetylcholine, there will be smooth muscle contraction. So that means it increases the gastric motility, isn't it? There will be gastric contraction. So that is this pathway. So 5-HT4 agonist, anything which stimulate or anything acts as an agonist, it cause the release of this acetylcholine, and it actually, so there will be myotonic motor neuron and there will be smooth muscle contraction. So there is acetylcholine here and there will be contraction of the smooth muscle. Okay, that is one pathway. It is intrinsic. Then now, there is another inhibitory nervous system that is inhibitory. So this is through 5-HT3. So here what is happening? This 5-HT3, it is actually inhibitory. Inhibitory means the neurotransmitter, that is the factor that is released, it is nitric oxide. So you know that nitric oxide, it causes smooth muscle relaxation. So in our body, in the intestine, for the peristalsis, there should be contraction and relaxation. So it should not be only contraction or only relaxation. Peristaltic movements means here it will be contracted, then relaxed. Then again, when it comes here, it will be contracted, relaxed. So there will be contraction followed by relaxation. So this contraction, this excitatory pathway causes the contraction, and this inhibitory pathway causes the relaxation. So that is the normal thing that is happening in our body or intestine or in the stomach. Okay, then there is another one called dopamine. Dopamine receptor, that is D2 receptors, are also present in the prejunctional neuron. Here. This is the smooth muscle. So this is the prejunctional. So here this D2 usually this will inhibit the release of this acetylcholine. The dopamine inhibits the release of acetylcholine, normal case. So this also adds to the relaxation process. So this is the normal pathway. Now we will see what is happening with our drug. So the metoclopramide, we have seen it is, yes. So it acts through the dopaminergic and serotonergic receptors. So there will be a dopamine antagonism as well as it will be acting through serotonergic. So we will read this, then we will go to the picture. So usually this is the action of dopamine. There is it inhibits the acetylcholine in the gastrointestinal tract and I am talking about dopamine, delay the gastric emptying and gastric dilatation and lower esophageal relaxation, sphincter relaxation will be there, and that will cause nausea and vomiting. That is the normal reaction. But metoclopramide, when we take, it will block these receptors. So opposite action. So there will be hastening of the gastric, hastening the gastric emptying. LES tone, lower esophageal sphincter tone, it will be augmented, and there will be acetylcholine release, and that is through dopamine. Okay, we will come to the next point again. And the central anti-dopamine D2, there is the metoclopramide also has a central D2 action. D2 blocking action, that is anti-dopaminergic or D2 blocking action, and so that is responsible for this anti-emetic property. So this metoclopramide, it has got action on the dopamine as well as serotonin. So second point, serotonin. We'll see the picture again. So I'll just read it out, then we will go to the picture. So 5-HT4 agonism, I told you there will be enhancement of acetylcholine release. So, there will be, this causes the, activate the excitatory interneurons, and the gastric hurrying and LES toning effects of metoclopramide are mainly by this action. So there will be increased release of acetylcholine. Whereas this 5-HT3 antagonism, so usually through 5-HT3 we have seen that there will be nitric oxide synthesis, but it is blocked. So the inhibitory neurons are blocked. So there will be facilitatory. That means nitric oxide is blocked, release. So there will be contraction. Okay, now we will see again. So metoclopramide, I told you it will be acting through the D2 receptors, dopamine blockade. So usually dopamine inhibit the acetylcholine. Now this is blocked. Dopamine receptors are blocked. So more of acetylcholine. So there will be smooth muscle contraction. Then now it is also acting through 5-HT4. This is 5-HT4. So there will be increased 5-HT4 agonism, not antagonism. So again, acetylcholine, it will be released. Now, through 5-HT3, 5-HT3, normally there is a relaxation, but that is inhibited. So there will be contraction. So altogether there will be smooth muscle contraction. So this increases the gastric emptying. So the contraction of the sphincter, gastric emptying, everything it is made faster by this metoclopramide. I think you have understood. Now, about the pharmacokinetics, the drug, you'd have heard of the drug perinom. This is nothing but perinom. So it is absorbed rapidly from the, from oral, sorry. It can be given orally, and orally action will take 1 hour. But if you are giving IM, it will take only 10 minutes. After IV, it will take only 2 minutes. Then interaction. So we have seen that there is a speed, the gastric emptying, the speed is made, faster. So the rate of absorption of some drugs, it will be affected, like aspirin, diazepam, digoxin, etc. So because of the emptying of gastric emptying is made faster. There is a gastric hurrying action because of that absorption. Because if it is hurried, means there is not time for absorption. So it may cause some reduction of the absorption of certain drugs. Then I think Parkinsonism, I don't know, was it taken for you, Parkinsonism? Hatif? Yes or no? No. Okay. So in Parkinsonism, there is actually there is a condition called Parkinsonism. There is for that we will be using there is a levodopa. There is a drug that will liberate dopamine. So, but this metoclopramide, because it blocks the dopamine receptors, it may abolish the therapeutic effect of levodopa. That is one interaction. Okay, we will study again when you study this Parkinsonism. Now, the metoclopramide, it is the adverse effect. Even though it is well tolerated, some people, it can cause dystonia. Dystonia, it is nothing but it is because of the dopamine blocking property. It is an extrapyramidal syndrome. So it is called dystonia, especially in children. You can see this child developing dystonia after metoclopramide. It is reversible. So the eyes will be going like that and the face like this. It is called oculogyric crisis. So that is these eyes are turned up. So this is one side effect of metoclopramide. But this can be prevented if you add promethazine or diphenhydramine, it is an antihistamine, or diazepam or lorazepam. If at all it happens immediately, you have to give any of this drug, then this can be reversed. So that is one problem with metoclopramide. It won't happen for all people, but sometimes it may happen. That is, those are prone. So metoclopramide, so nothing to worry about. It is just a side effect. You can treat with promethazine or diphenhydramine or diazepam or lorazepam. If you are injecting, this can be reversed. Now uses, so this is a prokinetic drug, so it can be used as metoclopramide. It can be used as an antiemetic. Antiemetic means many situations like post-operative, drug-induced vomiting will be there. We can give that. Then or radiation induced, or usually this anti-cancer drugs like cisplatin, it is highly emetogenic. So such cases we can use this metoclopramide. But another drug, that is ondansetron, that is the best drug for emetogen in anti-cancer therapy, but this can also be used. Then gastrokinetic, in some cases, some emergency situations, emergency surgeries, the patient would have taken food less than 4 hours before. So if you are giving anesthesia, he may vomit. So in such cases, if you are increasing the gastric emptying by giving gastrokinetic agents like metoclopramide, it is actually useful. And also certain gastric stasis conditions associated with diabetes or vagotomy, we can use this drug. Then dyspepsia, hiccups, you know what, I think you know what is hiccups. Hiccups, to stop hiccups, we can also use this metoclopramide. Then GERD or gastroesophageal reflux disease. We have seen that it will be causing the increasing the tone of the gastroesophageal that sphincter. So there won't be any reflux, backflow of fluid or any contents from the stomach to the esophagus. So it is used in case of GERD. But for GERD, the best drug it is PPI. And second is H2. But we can also use this metoclopramide because of the prokinetic property. Now domperidone. Domperidone, it is acting only on this dopamine receptors, D2 receptor antagonist. Domperidone. Okay. So this D2, but only one important point about this domperidone is that it won't cross the blood-brain barrier, but only poor crossing is there. So we have seen that metoclopramide, it will interfere with the action of levodopa. But domperidone, even though it is a D2 receptor antagonist, it won't cross the blood-brain barrier. So because of that, it won't affect the block the therapeutic effect of levodopa. This is it's the case with Parkinsonism. You can see the person will be like this, rigid, stooped posture, then trembling extremities and masked face, etc. So this is a typical Parkinsonism appearance. So such a person with the Parkinsonism, usually we will be giving levodopa. Levodopa will be converted to, when we take levodopa, it will go to brain and it will be converted to dopamine. And because in Parkinsonism, there is deficiency of dopamine. So it is useful in Parkinsonism. So this, dopamine, it acts, you know, dopamine, it acts through the dopamine receptors. But if the dopamine receptors are blocked, then there is no effect in Parkinsonism. So domperidone, but it won't cross the blood-brain barrier. Even though we are giving domperidone, it won't cross the blood-brain barrier, so it won't affect it won't block the therapeutic effect of levodopa in Parkinsonism. Okay, so again, so we have seen that it is having a D2 receptor blockage in the upper GAT. So we will see what is that D2 receptor blockade. So we have seen that D2 receptors. So in normal case, D2 will inhibit the acetylcholine release. So it is these receptors are blocked by domperidone in the periphery. So there will be more of acetylcholine and there will be smooth muscle contraction and there will be peristalsis. So that is the prokinetic activity of domperidone. And side effect, there is much, very less. All these are very safe drug, and but sometimes there will be loose stools because it is prokinetic. Then galactoria because D2 receptor block. Then if you are giving rapid IV injection, there is a chance of cardiac arrhythmia. So and it is an antiemetic for mild to moderate disease. You would have seen this drug Domstal. Domstal is nothing but domperidone. So it is an antiemetic as well as a prokinetic drug. So it is very safe drug. Okay. Now another drug that is prokinetic and it is related to metoclopramide. It is cisapride. But cisapride, because there are different problems. We will come to the next slide. So it is what is happening in cisapride. Its action is only through 5-HT4 agonism as well as 5-HT3 antagonism. So 5-HT4 agonism means there will be acetylcholine release. 5-HT3 antagonism means there will be again inhibit the nitric oxide and there will be again contraction. In addition, this via 5-HT4, it also promotes chloride secretion in the colon. So that will increase the water content of stools. So because of that, cisapride, if you are taking, it will produce loose stools also. So, but there is no action on the CTZ. But recently, it is actually suspended from marketing in most countries. India also it is banned in 2011. This is because of the serious ventricular arrhythmia and death. So cisapride, it was they were using frequently long back, but I mean before 2011. But now it is banned because of the ventricular arrhythmia. So that is cisapride only through 5-HT. So yes, 5-HT, I am just showing again 5-HT4 receptors as well as inhibiting the 5-HT3. So 5-HT4 means more of acetylcholine. 5-HT3, usually there will be nitric oxide synthesis and relaxation, but that is inhibited. So because of that, there will be increased smooth muscle contraction. So that is again the cisapride. Then another one, related one, cisapride, it is mosapride. It is again same similar action, 5-HT4 agonistic action and 5-HT3 antagonistic action. I think you are following it. 5-HT4 agonistic means ACH released. 5-HT3 antagonistic means that relaxation is prevented. That is nitric oxide formation is prevented. And there is no D2. So you have seen only 5-HT actions or serotonergic action only is there. So there won't be any D2 blocking action. So there won't be any extrapyramidal side effects because only those drugs that blocks the D2 will cause the extrapyramidal side effects. So, side effects, it is loose motion, abdominal pain can occur. Then indications, all these drugs are used for the same purposes, non-ulcer dyspepsia, diabetic gastroparesis, GERD, chronic constipation, etc. But GERD, I told you the best drug is proton pump inhibitor like omeprazole, rabeprazole, etc. 1 minute. Then another one, it is related one, that is etopride. So cisapride, mosapride and etopride. But etopride, there is some difference. It is produced in Japan. It is a D2 blocking as well as acetylcholine potentiating activity. But like other cisapride and mosapride, it has less affinity for 5-HT4. So it is a D2 blocking and anticholinesterase or acetylcholine potentiating activity. Then one another important factor about etopride is that it is metabolized by flavin monooxygenases. Usually many drugs are the cytochrome P450 inhibitors. P450 is the enzyme that is, but this is flavin monooxygenases. So because of that, drug interactions will not be there in case of etopride. Then the side effects, it will be similar to others, diarrhea, pain, galactorrhea, gynecomastia, etc. And indication, it is dyspepsia. So this galactorrhea, it is because of the D2 blocking action, dopaminergic blocking action. Whenever there is a dopamine block, there will be more of this prolactin and there will be galactorrhea. Then another drug, it is levosulfuride. Levosulfuride, another prokinetic agent. So this blocks central as well as peripheral D2. So peripheral D2, we have seen that picture because it inhibits the peripheral D2. There is a more release of acetylcholine, and that will lead to cause the prokinetic action. So it has got, but it is having some atypical antipsychotic effect and prokinetic as well as antiemetic property. And it is used in case of similar to others, dyspepsia, GERD, irritable bowel syndrome, same symptoms, same indications, levosulfuride. Okay. Then another one, it is cinitapride. Cinitapride, it was developed in Spain and marketed in Spain as well as Mexico, Argentina as well as India. India also it is there. Here it is similar to our metoclopramide. Blocks the dopamine D2 receptors as well as stimulate the 5-HT4 receptors. We have seen metoclopramide, it blocks D2 receptors as well as 5-HT4 receptors. So because it blocks the D2 receptors, chances of muscle dystonia, that is extrapyramidal side effect, it is there. And it is used for non-ulcer dyspepsia, delayed gastric emptying, GERD, etc. So muscle dystonia, that is, I have shown you one picture. So there will be dystonia, there is extrapyramidal syndrome, because whenever there is a blocking of D2, that will cause dystonia. Have you followed? Are you listening?
Yes, ma'am.
Yes.
Yes,
okay. Okay. Now, so that was okay. Thank you. That was about prokinetic agent. Now we will give another group of drug called digestants. Digestants, we would have taken many digestants in our life. I don't know, you young people, you would not have, but once you cross 40, 45, then we will be having the problem of all this belching, gas problem. So such cases, people will go for some digestants. So the digestants are actually substances intended to promote digestion of food. So it can be, this may contain proteolytic or amylolytic or lipolytic enzymes. So this is used for people, sometimes some people, they will not be having appetite. So in order to stimulate the appetite, these drugs may be given, or some dyspeptic symptoms, it may be used. But it is not good for the routine use. Now, we will see what are the important digestants. Pepsin. Pepsin is usually given along with the hydrochloric acid, that is given in atrophic gastritis, gastric carcinoma, pernicious anemia, etc. Rarely it is given. Then papain. So, you know, this is, what is this? Papaya? Yes or no? I think in Kerala, people are familiar with Sharat Chandran. Do you know what is this?
Yes, ma'am.
Have you seen this?
Yes,
What is shown here? Sharat Chandran. What is shown here?
yes, ma'am.
What is the fruit? Which fruit is shown here? This one.
Papaya, ma'am.
What is it? So unmute yourself and tell. Unmute your phone and tell. You are muted, so I can't hear you, Sharat. Hello. Hello, Sharat Chandran.
Yes, ma'am.
You have to, yes, unmute and tell me what is this fruit.
Papaya, ma'am.
Papaya, okay. So this papain is obtained from a raw papaya. It is not the fruit papaya, it is from the raw papaya. So this is a proteolytic enzyme. Then another one, pancreatin. Pancreatin, it is obtained from hog and pig pancreas. So this is the hog and pig. So from their pancreas, we will be getting, they have isolated pancreatic enzyme, and it consists of amylase, trypsin, lipase, etc. So it is used for patients with chronic pancreatitis. It is used, pancreatin. Then another one, it is diastase and decadiastase. So these are amylolytic enzymes obtained from the fungus Aspergillus oryzae. So diastase and decadiastase. Diastase and diastase. So this is obtained from Aspergillus oryzae. So have you seen this digestive enzymes? Anyone? Aristozyme or Digiplex? Hello?
No, ma'am.
No one has seen. So only your grandparents, they would have seen it. Nowadays, people are not for this, but because some places they will be using this. This is for increasing the appetite, for digestion, etc. Aristozyme or Digiplex. Digiplex, it will be along with this bottle. 2 tablets will be there. We have to mix it in this tonic, and we have to take 3 times. So that will increase your the appetite as well as digestion. So older people, they will be favoring this. So this is the aristozyme, and so you can see here aristozyme. The compound is diastase and pepsin. So we have seen already diastase. So that is there in this aristozyme. Then here, this is alpha amylase and pepsin, digiplex. So there is another preparation also with diastase and pepsin in this digiplex. It is alpha amylase. Okay. So these are the digestants or yes, digestants, appetite stimulants or digestants. Then another one that is used as a digestant, it is an anti-foaming agent actually, methyl polysiloxane. So it is a silicon polymer. It reduces. It is an anti-foaming. Foam means froth. Froth. It is an anti-foaming agent, and usually it will be all these antacid. We have seen last class antacids to the antacid digestants and anti-reflux preparations. This methyl polysiloxane which will be added, and this is an anti-foaming agent. So in most of the older people, they will be having every day they will be having some gas problem. So so this is an anti-foaming agent. So this is the methyl polysiloxane is added to any antacid preparation, this digene and gelusil, etc. And digestants, we have already snatstosane, etc. And other anti-reflux preparations, this methyl polysiloxane, it will be added. So it will be acting as an anti-foaming agent. It is very good remedy for those who are having the complaint of this gas. Gas is not the cooking gas, the other gas in the stomach, in the intestine, that gas I am talking. So it is a remedy for gas, a very common gastric complaint in the elderly people. Above 50, 60, 70, etc. They'll every day they'll be having. I don't know whether in your family maybe only your parents are there, but if your grandparents are there, they will be complaining of gas problems. So such cases, we can use this drug. That is this is not given as such. It is added to antacids, digestants, and anti-reflux preparations. So I think that was the last slide. Thank you.